Welcome to Mind Matters, our weekly program dedicated to exploring complex issues in mental health. Today, we delve into a treatment that has long been a subject of intense debate: electroconvulsive therapy, or ECT. Is it a vital, life-saving procedure for those with severe mental illness, or does it pose unacceptable risks to patient well-being? Joining us to discuss this are Dr. Ben Carter, a psychiatrist with extensive experience in administering ECT and a proponent of its careful application, and Ms. Lena Hansen, a patient advocate and vocal critic of ECT who raises significant concerns about its impact. Thank you both for being here to share your perspectives on this challenging topic.
Thank you for having me, Sarah. It's crucial we discuss ECT with clarity and factual information. Modern electroconvulsive therapy is a carefully controlled medical procedure administered under general anesthesia with muscle relaxants. Its primary purpose is to provide rapid and significant relief from severe psychiatric symptoms when other treatments have failed or are not suitable. We see remarkable efficacy with ECT in treating conditions such as treatment-resistant major depression, where individuals haven't responded to multiple medication trials or psychotherapy. It's also highly effective for severe mania, particularly in bipolar disorder, and for catatonia, a state where individuals may be unresponsive and unable to care for themselves. The historical perceptions of ECT, often shaped by outdated practices or dramatic portrayals, are far removed from today's reality. Significant advancements in how ECT is administered, including precise electrode placement like unilateral or bifrontal options, aim to maximize therapeutic benefit while minimizing cognitive side effects. The use of brief pulse stimuli, as opposed to older sine wave stimuli, is another key improvement that has enhanced the safety profile. It's important to understand that ECT is not a first-line treatment. It's typically considered when other less invasive options have proven insufficient, or when the severity of the illness, such as acute suicidality, necessitates rapid intervention. The ethical framework surrounding ECT is robust. Informed consent is paramount. Patients, and where appropriate their families, are provided with comprehensive information about the procedure, its potential benefits, and its risks. The decision to proceed with ECT is made collaboratively after a thorough assessment by a multidisciplinary team. It's a carefully considered option, reserved for specific, severe circumstances where its potential to alleviate profound suffering outweighs the potential downsides. We have seen it restore individuals to a functional state, enabling them to re-engage with their lives, their families, and further therapeutic interventions. It can be, quite literally, a life-saving treatment.
Thank you, Sarah. And Dr. Carter, I acknowledge the severe and distressing nature of the conditions ECT is used to treat. No one disputes the profound suffering involved. However, my primary concern, and the concern of many patients and advocates, lies with the significant and often downplayed side effects, particularly cognitive ones. We're talking about memory loss, both retrograde, affecting memories from before treatment, and anterograde, impacting the ability to form new memories. While proponents often describe this memory loss as, quote, temporary or patchy, for many individuals it can be extensive, persistent, and deeply disruptive to their identity and daily functioning. Beyond memory, there are concerns about effects on executive function, things like planning, organizing, and problem solving. These are crucial for independent living and quality of life. The patient experience is often quite different from the clinical descriptions. Imagine waking up not knowing where you are, or forgetting significant life events, or struggling to retain information vital for your work or studies. This isn't just a minor inconvenience. It can be a devastating loss that impacts relationships, careers, and a person's sense of self. Furthermore, I question how consistently ECT is truly a last resort. Are all alternative treatments, including innovative psychotherapies, neuromodulation techniques, and comprehensive psychosocial support, always exhausted before ECT is recommended? There's a need for greater transparency and scrutiny in this regard. Sometimes, it feels like a shortcut, rather than a path taken after every other avenue has been meticulously explored. Ethically, the issue of informed consent is incredibly complex when a patient is in the throes of severe depression or psychosis. How truly informed can consent be when an individual's cognitive state is already compromised by their illness? There's an inherent power imbalance between the medical team and the vulnerable patient. We need to ensure that patients are not only given information, but also genuinely understand the potential for life-altering side effects, not just the potential benefits. The subjective nature of this understanding is a critical point of concern.
Thank you both for those comprehensive opening statements. Dr. Carter, you've highlighted the advancements and efficacy of modern ECT in severe cases. Ms. Hansen, you've raised critical points about cognitive side effects and the complexities of informed consent. Let's now move into a more direct discussion of these differing perspectives.
Ms. Hansen, I understand and validate the concerns regarding cognitive side effects, particularly memory loss. These are not dismissed by clinicians. However, it's essential to contextualize them. The type and severity of memory impairment can vary significantly among individuals. Modern ECT techniques, such as unilateral electrode placement and ultra-brief pulse stimulation, are specifically designed to minimize these effects compared to older methods. For many patients, the memory disturbances are predominantly around the period of treatment itself, and tend to resolve within weeks or a few months post-treatment. While any memory loss is regrettable, we must weigh this against the debilitating and often life-threatening nature of untreated severe depression or catatonia. Severe depression itself profoundly impairs cognitive function, including memory and concentration. Sometimes, patients report improved cognition after ECT as their depression lifts. The clinical evidence supporting ECT's efficacy, especially in treatment-resistant depression, is substantial. Multiple studies and meta-analyses confirm its status as one of the most effective treatments available for these severe conditions. It's not a decision taken lightly. Rigorous assessment protocols are in place. This includes a thorough psychiatric evaluation, medical workup, and often consultation with other specialists. Patients are monitored closely during and after the ECT course for both therapeutic response and any adverse effects, including cognitive changes which are systematically assessed. The narrative that alternatives are not explored is often inaccurate. ECT is typically pursued after a documented failure of multiple other appropriate treatments, or when the clinical situation is so acute that a rapid, effective response is paramount for safety.
Dr. Carter, while I appreciate the acknowledgement of cognitive effects, the term temporary can be misleading and, frankly, dismissive of the lived experience of many. For some individuals, the memory loss is not short-lived. It can be permanent and can erase significant personal history, which is a profound loss. There are numerous patient testimonies and qualitative research findings that paint a far more troubling picture than often presented in clinical summaries. These voices speak of struggling with daily tasks, losing cherished memories of family and life events, and feeling a diminished sense of self. These are not just patchy losses. They are holes in the fabric of their lives. To suggest that this is an acceptable trade-off without fully exploring every single less invasive option is problematic. This brings me to the point about advocating for increased funding and research into innovative, less invasive treatments. If ECT is truly a last resort, then we should be pouring resources into developing more alternatives so that fewer people have to reach that last resort. Why isn't there a greater push for advancements in treatments like transcranial magnetic stimulation, TMS, ketamine therapy, or even novel psychotherapeutic approaches tailored for severe conditions? And regarding informed consent, even with systematic assessments, the challenge remains. When a person is deeply unwell, their ability to weigh complex information and potential long-term consequences is inherently compromised. Are consent forms truly capturing the potential for persistent, disabling cognitive deficits, or are they skewed towards emphasizing benefits? The process needs to be far more patient-centered and perhaps involve independent advocates to ensure genuine understanding. The subjective nature of this understanding is a critical point of concern.
We've heard compelling arguments from both sides, highlighting the efficacy and necessity of ECT in certain situations, and also the serious concerns about its impact and the consent process. Considering these strong views, I'd like to ask both of you, what do you believe is the most critical next step in ensuring patient well-being regarding ECT? Should the priority be more research into refining ECT, stricter guidelines for its application, or perhaps developing far better patient support systems and alternative treatments?
That's a vital question, Sarah. From my perspective, the most critical next steps involve a multi-pronged approach. Continued research is essential, not just to further refine ECT techniques to minimize side effects, but also to better identify which patients are most likely to benefit and who might be at higher risk for adverse effects. Better public and even professional understanding of modern ECT is also needed to dispel myths and ensure discussions are based on current practice. Ultimately, ECT, when used judiciously and ethically, remains an indispensable, often life-saving treatment for a specific group of severely ill patients for whom other options have failed. We must preserve this option while striving to improve it.
For me, Sarah, the most critical next step is a significant shift towards prioritizing and heavily investing in the research and development of non-invasive alternatives. While refinement of ECT might offer marginal improvements, the fundamental act of inducing a seizure remains a blunt instrument with inherent risks. We must also focus on truly empowering the patient's voice in all treatment decisions, ensuring that informed consent is a transparent, supportive, and ongoing dialogue, not a one-time procedure. Greater caution, a more holistic approach to severe mental illness that explores all avenues of support, and a relentless pursuit of less harmful interventions should be our guiding principles. Patient well-being must always come first, beyond just symptom reduction.
Dr. Ben Carter and Ms. Lena Hansen, thank you both for an incredibly insightful and thought-provoking discussion today on Mind Matters. You've presented nuanced perspectives that underscore the complexities surrounding electroconvulsive therapy. It's clear that the debate is ongoing, highlighting the critical importance of balancing treatment efficacy with patient rights, autonomy, and long-term well-being. The journey of mental health treatment is deeply personal and multifaceted, and conversations like these are essential to navigate its challenging landscape responsibly. Thank you to our listeners for joining us.